Thanks a lot, Julie. Really appreciate everybody joining in and spending this afternoon. I'll try and keep this brief. I'd love to hear, your points of view. If you have any questions, any comments, anything else that you've seen in the market. We're not, as you can imagine, we're not here to talk about AGS Health, even though we're representing them. I come more as an industry expert to talk to you about what's happening on financial clearance, more importantly, and I'll share some of the things that I've seen in the market myself, what's happening on the payer front, give you a little bit of view of what's happening on the other side of the fence, right? And I'll also talk a little bit about what we specifically are doing at AGS Health to address some of these things, right? And for a quick introduction, I'm the CTO of AGS Health. I've joined beginning of 2021. Before this, I was an entrepreneur for a couple of years. Before that, I was the chief data officer at Aetna, one of the larger payers in the US. And before that, I was heading insurance and healthcare strategic consulting for Cognizant Technology Solutions. I've spent a fair bit of time on the payer side, and so I kind of have had an opportunity to look at how payers typically look at some of these middle office, back office operations, more specifically claims adjudication and prior authorization. Right? So let me go into the slides. I will present a point of view in terms of what prior auth is, right? This is kind of preaching to the choir, I get it. But I thought it'll be important for me to kind of set the stage for why prior authorization is one of the more important things to look at and kind of re-emphasize the priority that it's being given in the market, right? I'm sure some of you must have seen startups raising a ton of money. Prior auth now is one of them. I know one which is being promoted in Boston, which raised maybe 15 million, I think a couple of months ago, purely to look at prior authorization. So payers and providers both recognize that prior authorization has become way too unwieldy, clunky workflows, systems don't talk to each other. And so there is a tremendous amount of waste in the system, right? And prior authorization is simply used by the payers as a gatekeeper effect. What that means is that there is a slowdown in velocity of care, sometimes impacting health outcomes adversely. It also means that the lower star rating due to experience. And the reality is that the payers approve these prior authorizations anyway, right? They most probably make the providers and patients jump through hoops, but 90% of the times they're approving it anyways. But the reality is that simplifying prior authorization reduces significant operational costs across the spectrum for plans, patients, and providers. And this is from a survey done by CAQH. Some of you must have seen this in other forums or in other formats, but I want to bring your attention to what's happening on the manual front on prior authorization, right? It costs the payers about $3, as you can see, but it costs the providers $10, right? It's almost like 3.5x. A lot of innovation is being done, at least as I've seen on the payer side, but the pain from a cost perspective is most probably more on the provider side. And so the urgency should be on the provider side too. And if you look at the volumes, you'll see that there's a partial electronic and the provider volumes are about 52 million and it forms the bulk of the volume. But the reality is that partial electronic is like a catch-all bucket, right? Even if like 5% or the tail end of it is automated, you can throw it in that catch-all bucket of partial electronic. It just means that there's some automation, some transformation has happened, re-engineering has happened, but it could very well be that the majority of the workflow is still very manual, right? And so that's where a bulk of those volumes fall. And providers typically spend on an average 21 minutes on the prior auth request and a maximum time of 45 minutes. And in terms of savings, for the medical industry, it's close to $500 million. These numbers are 2019, so I'm assuming they've only grown. I don't think the prior numbers would have changed much simply because COVID has meant that a lot of transformation initiatives kind of took a back step. And so I don't think that the manual, the wedge manually may still be coming in manually and not so much electronically. And there is a potential average time savings of per transaction of 70 minutes. So the way that we at AGS Health are looking at prior authorization is we're looking at it from three core areas, right? One of my mentors always used to say that they eat an apple is to eat it one bite at a time. And so rather than looking at the whole of prior authorization workflow and trying to solve for it, we divided it into three categories, and we are approaching each one in a different way. And the third one is actually adjudicating the prior authorization requests, right? This is more on the payer side, but I wanted to give the folks on this webinar a chance to look at what's happening on the other side of the fence, right? I did a very large transformation project for one of those about 1.5 years ago. And I wanted to give you all a glimpse of how these payers are looking at automation, using data, using insights to build more digital widgets so that the adjudication process is much more seamless, right? The payers themselves have kind of backed themselves into a corner by insisting on prior authorization, but their processes are still so clunky with no workflows, everything going through fax, and some of these things have to be sent offshore to be able to translate it and then put into some kind of a workflow tool. So they themselves are in a little bit of a bind, and so they are doing some significant things in terms of transformation. And I wanted to give you all a perspective of what's happening on the other side. The first one, as you can see, is what I call as a Domino's pizza tracker or a FedEx kind of a problem. The first one is, how does intake of a prior authorization request look like? And once it's done, how does the tracking, monitoring, and status update look like, right? So essentially, it's like ordering a Domino's pizza and looking at the tracker to see whether it's been thrown in the oven, is it being garnished with vegetables, like whatever else is happening, right? The second thing is the clinical documentation required for prior authorization. A lot of effort and time is actually spent in the back and forth that happens between the payers and providers, as you can imagine, right? Again, some of you know these issues like the back of your hand. The way that we are looking at this is how can we actually determine what's the clinical documentation required for prior authorization, right? And can it be what I call this the TurboTax kind of approach, in the sense that I'm a technology nerd. I look at crypto, I look at trading in cryptocurrencies and all, but when it's time to file my taxes, I always dread it because nobody can understand some of these tax laws, right? Even the smarter ones cannot. And so the way that TurboTax actually approach this is they develop their software, and there's so much of intuitive design has gone into it. Like, for example, if I had stocks and I sold them and I made some money on it, if I just tell TurboTax that I had I sold some stocks, it takes you through a series of questions, right? Did you have stocks? Yes. Did you sell them? Yes. Did you make money on it? Yes. Can you tell us the amount, right? So it's a very intuitive, user-friendly, layman's kind of a perspective that TurboTax brings to the table, and that's how we're looking at determining the clinical documentation. And then adjudication of the prior authorization, which is the third one. I'll give you a little perspective, as I said, on how the payers are thinking about it. So in terms of intake tracking and monitoring portal for utilization management, again, we divided this into three problem areas. One is that the first one is there like a front door that everybody can use for a prior auth intake, which is with a persuasive and guided user interface. The second one is, I'm sure some of you must have seen this application called the Slack, which is typically a collaboration tool like Teams or Skype, but this is one of the more recent ones acquired by Salesforce. And is there like Slack typically allows you to create channels where a bunch of people can be on a similar channel rather than this direct messaging between two individuals, right? And so can there be like a Slack kind of an exchange? And then the pre-auth shipping tracker, which is what I talked about when I said it's like a Domino's pizza tracker, right? In terms of prior auth, what it basically does is if the providers have a chance to look at, have the chance to use a prior auth intake, and it's one common interface that's being used to input the request, irrespective of the payer, then that's the kind of a solution that the providers are looking for, right? Because I've seen payers create their own individual prior authorization portals. A chief digital officer joins, a Cigna or an Aetna or BCS Mass. Now they want to create a prior authorization portal, but on the provider side, that means that they have to the providers have to contend with like remembering 10 different portals, 10 different usernames and passwords, right? And while the payer might think that they have solved for it elegantly using some kind of digital tools, most probably they haven't actually made it easy for the providers to navigate all these different portals, right? But if there is one common portal that the providers can use, then it creates a digital record during intake. Now there is some kind of a workflow that's tracking this request. And also there is a guided intake process, right, to determine the need for clinical documentation. I'll talk about this as part of number 2. And the second one is what I call as a digital document exchange. Again, this I know that the payers will spend a lot of money reducing turnaround times for member contact centers, but they're not the same when it comes to provider contact centers, right? They don't put a lot of money. They don't mind when the provider calls. They don't mind the providers being on the phone, during whole time, just waiting for somebody to pick up on the other side, right? The way to circumvent all this waste is to have some kind of a digital exchange where whatever request is coming back from the provider, from the payer, the providers have a chance to look at it and submit it in that particular channel, and the channel picks it up and then resubmits it back if necessary into the payer portal, right? And especially apps like Microsoft Teams and Slack, initially all these collaboration tools were walled off. You couldn't let people from another enterprise or another company talk to you using those channels or using those tools, but these tools now allow you to interact with folks from another company, right? So in this case, it's providers and payers on the same digital channel. And thirdly, the pre-auth shipping tracker, I actually took this picture from Amazon, I kind of cropped it and I added my own text there. All the provider portals right now have some updates that they're usually putting there. And one of the things that we're doing is, we're building using RPA and using analytics. We're building bots to be able to crawl these payer portals, bring these updates back and put it in one place so that the providers have a chance to understand where the status of it is, right? As you can see, I'm not, while from a technology perspective, each one of these things have an underlying infrastructure layer. It's not necessary that one is dependent on the other, right? All these things can actually be done individually. And in terms of making some of these transformation changes, we at AGS Health, we're making sure that these are not just exercises that we're doing because we want to be a technology-led company and it's intellectually stimulating, but we are also looking at, does it actually make a difference, right? Does it make a difference to the providers? Is there a reduction in faxes, emails, and phones, right? Is there an increase in auto approvals? Is there a reduction in clinical reviews? More importantly, is the turnaround time coming down, right? Member sat and provider sat are a little bit more qualitative, but one of the key things to make sure is that these initiatives transformation exercises are actually making a difference in terms of measurable KPIs. And the second one, and this is a little more complex, and we are actively looking for partners who we can partner with, and who can kind of engage with us and help us think through this a little bit. This is the determining the clinical documentation, right? So what we did is we looked at, I talked about a front door. The front door is the one that we use for submitting the prior auth request. But how can we make it more intuitive by making sure that the person who's submitting this prior auth request has an opportunity to do it in the right way, right? They're submitting all the complete documentation in one go, rather than this back and forth that usually happens, right? So I took this, we took this form from BCBS, North Carolina. This is an actual prior auth request that you can just download. It's a PDF that's available on Google. And typically, this is how it looks like, right? I mean, obviously, this is not intuitive. We didn't want to put screens that we're working on, but I just took a screenshot of that particular PDF. So, for example, if the user clicks on, it's a surgery and it's a procedure, then it goes to this particular screen, and the user has an opportunity to enter what they're actually looking at, right? For example, it's ITP, which is an autoimmune disorder where the platelets go down, the ICD-9 codes, and what is the clinical procedure for this? It's a surgical splenectomy, right? Now, while the CPT code is correct, and while that's the right clinical pathway for ITP, what the payers might insist on is that, hey, you can't just arrive at splenectomy right away. You should have gone through certain clinical pathways, and can you submit the earlier clinical pathways that were taken, right? And so, for example, if it's this is a clinical pathway that's recommended for treatment of ITP, they should have gone through, let's say, a prednisone, which is a corticosteroid. And if there is still active bleeding, then they should have gone through a platelet transfusion called as IVIG. And if that hasn't worked and bleeding persists, that's when they go for consult with somebody else. And then at some point in time, you arrive at the clinical, the laparoscopy procedure, right? So the payer might insist on, have you gone through all these clinical pathways before coming to this decision? And they may insist on some of these, blood reports, platelet count reports being submitted beforehand. And so if you can use these clinical pathways, which are published and which are widely available, and we can use these clinical pathways to, and using machine learning, if we can determine what is it that the payer is going to potentially ask for in the first go, and if we can make that intuitive enough, that's when we will eliminate all this back and forth, right? And we are actively thinking through at AGS Health in terms of how do we achieve this? Can we do this for some specialties? Which ones are more amenable to this kind of rule, heuristic / machine learning kind of an approach, right? The third one is the adjudicating the prior authorization request. As I said, I did a large transformation program for one of the larger blues. And as part of that, we analyzed some Medicare data, which was anonymized. And if you look at this particular chart, on the left-hand, on the y-axis, you'll see this is the cost of care prevented, right? For example, if the service request came in for $10,000 and only $9,000 was approved, the cost of care prevented is $1,000 there, right? And the cost of care per procedure is what you see on the x-axis, ranging from low to high. And the admin cost typically that the payer has is about $25 to $40 in adjudicating each prior auth request. And you'll see, I've changed the numbers a little bit because I didn't want to put the same exact numbers, but these are in the ballpark. As you'll see, 30 to 20% of the total prior auth volumes, the cost of care prevented is less than $10. And so the payers are actually spending more money in adjudicating this request than the money, than the cost of care that they're actually preventing, right? And they recognize this, by the way, right? It's most probably, blasphemy to go to a director or a medical economics director on the payer side to go and say, hey, let's remove some codes from the prior authorization list, right? I'm sure they wouldn't want to listen to that. But they're getting around to the fact that they're actually, are approving these anyways, and there's not a lot of savings, right? And so there are three things that payers typically are looking at least the big ones, right? And you should expect the smaller ones to follow through. For codes with low cost of care for a procedure, should the payers consider removal from PA, right? It's the low exposure, the exposure risk is low, and it's an improved provider member experience. For the codes with mid-range cost of care procedure, payers are considering direct auto approval, right? They are building rules engines and some kind of auto approval decision making, so that the prior auth goes through the workflow but gets auto approved anyways if it meets certain criteria. The provider may not know that it's getting auto approved because it's behind a wall, but it has a sentinel effect on the providers, right? I mean, so that's what the payers are looking for. But some of these cost of care procedures which kind of fall in the middle, that's what they're looking at. And the ones where typically it's high, the payers are looking at deploying intelligent approval tools to optimize the ROI, right? Like cognitive utilization management. And what the payers are looking at, it takes two parties to tango here, right? If the payers really want to achieve this zero-touch approval that is there at the bottom left, and typically they're looking at like 30% of this, it means that the providers are, the intake optimization is well streamlined, right? Right when the intake happens, it's done in the right way. There is completeness of data. There is a consolidated EMR, and so there is a tremendous dependency on the providers being able to do the right thing when they're submitting the request, so that the payers have a chance to reduce the turnaround time and go to zero-touch approval. If on the middle state, where the automation is based on business rules, or there is a core AI algorithm, it again depends on the same thing, right? It's an enhanced rules engine, ML-based data models. But all these are only as good as the data completeness, right? If the providers submit at time, they have a chance to auto-approve this, and so therefore reduce the turnaround time. And if you're looking at the more complex ones, this typically require the nurse assistant. But if they're managed through workflow and there is an escalation matrix, there is an opportunity to streamline them and make sure that only the more complex ones and the ones that require a clinical director usually go through it. And this is what, again, I've changed the numbers a little bit here, but when we presented to the senior leadership on the payer side, one of the things that we were talking about is, can we improve the auto approvals in real time from 0 to 10? They were actually at like 0%, right? From 0 to 10% to 25 to 35%. AI-led approvals with zero touch, again, from 0% to 25 to 35%, and manual approvals decrease from what it is currently to 30 to 50%. Hopefully, the payers are able to get their act together and kind of recognize that they're not adding any value by having a bunch of codes that need to go through prior auth. They will simply not do away with some of these things because, as you can recognize, there's like a gatekeeper effect. But they're also trying to do the right thing, and in the next 1 to 2 years, we'll see some innovation happening on there. And again, I would love to hear. We'll take a pause in terms of hearing your comments, hearing any questions. I'd love to hear about if you've seen anything in the market, any other players that you're working with actively. We're here to learn as much as talk about it, and I'd love to get your perspective. But I'll take just 2 minutes to talk about AGS Health. We've been around for a little more than 10 years. We're one of the larger service providers providing coding, full service accounts receivable and financial clearance services to providers. We have locations across 5 different locations. I've got a headquarters in DC. And from a services perspective, as you can see, we are we're in the front end. We do prior authorization, eligibility, and benefit verification. From a coding and auditing perspective, we just 2 months ago or 3 months ago, we did a large acquisition of computer-assisted coding software using NLP capabilities, and we are looking at leveraging the NLP capabilities across both prior authorization and also across accounts receivable. And one of the key things that we at AGS Health are very keen about is that while our bread and butter is, we are a services-led company, we want to make sure that these are technology-led services, right? We simply don't want this to be, a labor or a manually driven services line, but we want to make sure that we add value to the customers. And so since the last 2 years, we've made a significant pivot in terms of investing in technology resources, tools like AI, machine learning, and NLP. And we are actively deploying some of these digital transformation tools to help us deliver our services in a much more differentiated manner, right? Better quality, better turnaround time, and making sure that we're actually adding value to the customer rather than, here's a resource, give us a widget and we'll work on it, right? And so we're doing some really exciting and innovative work using technology to transform some of these service lines. And, we're more than happy to talk about what we're doing in each one of these if you would like to get in touch with us at some point in time. But let me take a pause here and see if you have any questions, any comments that you'd love to hear. Now, more importantly, we'd love to hear your point of view and just do some of the things that I talked about resonate with you.
And whoever has a question, go ahead and unmute or go ahead and type it in the chat box. Are there any questions or thoughts or that you might have? We'll see if we get any takers. I don't have any questions.
Either I was really good, Julie, and they have like no questions now because they have.
Exactly. Well, we're recording this session and we'll put it on our website. We'll give you back 30 minutes of your time, and we appreciate everybody joining today. KHAM appreciates you, and if you're not a member of KHAM, well, we can help you there. Take care, everyone. Have a great day.